Hello, everyone, and welcome to Chapter 22 on the respiratory system infections. Just like in Chapter 21, we are going to start by covering a little bit of basic anatomy of the respiratory system. And when we tackle respiratory system infections, we are going to divide these up by first talking about infections of the upper respiratory system and then talking about infections of the lower respiratory system. So the upper respiratory system essentially includes everything from your trachea, or in other words, your windpipe, and up. So we have your larynx or your voice box, your pharynx, which is the technical term for your throat, your tonsils, your oral cavity or your mouth, your nasal cavity, your sinuses, and your auditory or eustachian tube, which runs from your ear down to the back of your throat. Your upper respiratory system is home to a variety of normal microbiota. Staphylococcus epidermidis, which we also saw in our discussion of the skin, is a very common member, as well as the genera Corynebacterium, Propionibacterium, Haemophilus, Neisseria, and as far as fungi go, Candida. So when you see this designation SPP after a genus, this means several species within this genus. So in other words, a variety of different species of Corynebacterium, a variety of different species of Propionibacterium, and etc. As far as diseases of the upper respiratory systems go, there are a few terms that you'll hear used when talking about inflammation and infection of these different components. Pharyngitis, remember the pharynx is the throat, so pharyngitis is inflammation of the mucous membranes of the throat. Laryngitis, the larynx is your voice box, and so laryngitis is inflammation of the voice box that affects the ability to speak, and this is what can cause you to quote unquote lose your voice. Tonsillitis is inflammation of the tonsils, and lastly, sinusitis is infection of the sinus, which usually comes with heavy mucus discharge, as many of us are probably familiar with. So now that we've laid down some terminology, let's take a look at the list of infections of the upper respiratory system that we're going to be surveying. We have 4 bacterial infections, and we have 1 viral infection. And after we make it through these, we are going to move on to infections of the lower respiratory system. So let's get started with streptococcal pharyngitis. This is also more commonly known as strep throat. It is caused by the species Streptococcus pyogenes, and it is inflammation of the throat, or in other words, the pharynx, accompanied by fever, and also often accompanied by tonsillitis. Streptococcal pharyngitis is transmitted via droplet transmission through respiratory expulsions, and it is typically diagnosed with a throat swab in a culture to determine whether Streptococcus pyogenes, the bacterium, is indeed the agent causing the infection. And this is important because the majority of cases of pharyngitis are actually caused by viruses, not by bacteria. And so before being prescribed an antibiotic, the nature of the infection needs to be confirmed as bacterial. And if it's bacterial, that specifically needs to be confirmed as being caused by Streptococcus pyogenes with this throat swab and culture. If a culture does confirm Strep pyogenes, then it's usually treated effectively with beta-lactams, which is the group of antibiotics that you remember we've learned about previously. They're inhibitors of peptidoglycan synthesis, and they are especially effective against gram-positive species such as Streptococcus pyogenes. And penicillin, for example, is one of these beta-lactam antibiotics. So in our first checkpoint, now that we've heard about Streptococcus pyogenes in the upper respiratory system, I'd like to remind you that we've also heard about it in Chapter 21 when we went over skin infections. And in this checkpoint, I'd like you to tell me 1 skin infection we learned about in that chapter that is caused by Streptococcus pyogenes. and tell me what its signs and symptoms are. Now, we're not done talking about Streptococcus pyogenes yet, because our second infection on the list, scarlet fever, is also related to streptococcal pharyngitis. It's sort of an advanced stage of strep throat, where the case of strep throat is caused by a special strain of Streptococcus pyogenes that produces an erythrogenic toxin. In other words, a toxin that causes reddening symptoms. Not all strains of Streptococcus pyogenes produce this reddening toxin though, and the gene for the toxin is actually the result of this bacterium, S. pyogenes, undergoing infection itself by a temperate bacteriophage. So here again, we're going to look at a checkpoint that will allow us to review this concept. What do temperate bacteriophages do in their bacterial hosts when they perform the lysogenic cycle? And how is this as it applies to strep throat, scarlet fever, Streptococcus pyogenes, an example of that phenomenon? So getting back to scarlet fever. Scarlet fever is an infection that emerges after a person is experiencing streptococcal pharyngitis or strep throat, which can manifest itself as scarlet fever if the strain that they are infected with produces this erythrogenic toxins. So the usual signs and symptoms of strep throat are present, but those signs and symptoms are additionally accompanied by a pinkish red skin rash, as you can see in the upper photo, as well as a spotted tongue that later become enlarged, as you can see in the lower photo. So these additional symptoms are caused by that unique erythrogenic toxin not present in all strains of Streptococcus pyogenes, only ones that have been infected by a bacteriophage that gives them this trait. Also noteworthy, scarlet fever has also been known to arise as a complication of streptococcal skin infections. So as we've discussed, Streptococcus pyogenes is a pathogen not only of the throat, but also of the skin. So scarlet fever can arise from a strep throat infection, or it can arise from a streptococcal skin infection. Next, we have diphtheria. This disease is caused by an exotoxin produced by the species Corynebacterium diphtheriae. Here, we can see the bacterium in this microscopy image differentiated with an Albert stain, which is a staining procedure that allows you to identify bacteria that contain these special types of inclusion bodies that store phosphate, of which Corynebacterium diphtheriae is the primary one of clinical significance. And so we can see at the polar ends of these rod-shaped bacteria, we have these special phosphate storing inclusions. Interestingly, members of this group of bacteria, Corynebacterium diphtheriae, are normal residents of your throat microbiome. However, they can become virulent after a lysogenic infection by a temperate bacteriophage, just like we saw with Streptococcus pyogenes when it came to the difference between your standard case of strep throat and scarlet fever. The hallmark sign of diphtheria is a combination of dead cells, pus, and fibrin forming this leathery gray material called a pseudomembrane in the back of the throat. And that's what you see in this image right here. So the exotoxin produced by these bacteria is extremely potent. It will kill the cells in your mucous membrane of your throat, and then those cells sort of merge with this inflammatory pus that's been produced in your fibrin connective tissue to form this material, this pseudomembrane. And if the extent of this pseudomembrane develops to the point where it blocks the pharynx or the trachea, then it can lead to suffocation, which is why diphtheria is so dangerous, even though we might not recognize it as such these days, because in the 1930s, it was the leading cause of death among children in the United States. However, now, due to protection by the DTaP vaccine, which stands for diphtheria, tetanus, and pertussis vaccine, because of the protection offered by this vaccine, there are now 5 or fewer cases in the US every year, thankfully. Next, we have otitis media. This is also known as an earache or a classic ear infection, specifically of the middle ear, and it is often caused by encapsulated strains of Streptococcus pneumoniae, although there are a wide variety of other pathogens that are both bacterial and viral in origin that can infect the middle ear. Streptococcus pneumoniae, specifically the Streptococcus pneumoniae within a capsule, is very commonly the cause. The result of this infection is a pus buildup that puts pressure on the eardrum and the eustachian tube, which leads to inflammation, as you can see in this image of a normal eardrum on top versus one in an infected individual on the bottom. And the local infection can often lead to other systemic signs and symptoms like fever, vomiting, intense pain in the ear, of course. And if you're a parent, you may know that these infections are much more common among children. And the reasons why are that their auditory tubes are more narrow and they are more horizontal in relation to the rest of the body. And as we grow, our auditory tubes get larger and they also get more vertical. And this means that they are less likely to trap bacteria and are able to flush out bacteria using the assistance of gravity. And in children, this is not the case because they have small, narrow auditory tubes, and because of this, they trap bacteria more easily, and the horizontal angle of their auditory tubes allow those bacteria to avoid being flushed out by our natural physical mechanisms of our immune system. So this is why infections of the ear are more common among small children as compared to adults. So I just mentioned that encapsulated Streptococcus pneumoniae is one of the more common causes of otitis media. Thinking back to what we've learned about bacterial structure, in this checkpoint, I'd like you to tell me what it means for this bacterium to be encapsulated, and in what way would that allow this bacterium to be more virulent and lead to the infection, otitis media. So this completes our discussion of the bacterial upper respiratory system infections that we have chosen to focus on. And now we're going to take a look at our one and only viral upper respiratory system infection, and that is the common cold. And so the common cold is not actually the common cold because it's more like the common colds. It can be caused by over 200 different viruses that we know of. So there's many different causes of this thing we conceptualize as the cold. And despite this high level of variety, there are some usual suspects that are more common than others. 30 to 50% of common cold causing viruses belong to the group known as rhinoviruses, and 10 to 15% belong to the group known as coronaviruses. Probably sounds familiar, but we'll get back to that later. Adenoviruses are also one of the more frequent causes. And because there is such a great variety in the viruses that cause the common cold, it is very unlikely that there will ever be a universal cold cure because it's caused by so many different viruses, and it's so unlikely that anyone will ever become completely immune to the common cold because you would have to catch every possible virus and develop immunity to each one, and many of these viruses don't actually provide lasting lifelong immunity. The viruses that cause the common cold prefer the slightly lower temperature that is associated with your upper respiratory system. That is the temperature at which they are better able to reproduce. So they tend not to migrate into the lower respiratory system. And also because, again, this is a viral infection, antibiotics are not effective against these viruses. There are medications that may help control the symptoms and signs, for example, fever reducers and antihistamines, but these don't actually fight the virus. And antibiotic prescriptions likewise will not do anything to help cure these diseases because they are viral in origin. So this completes our look at the upper respiratory system infections. And now we're moving on to the lower respiratory system. So let's do a quick examination of some of the important anatomical structures that we see in the lower respiratory system. In the upper respiratory system, we left off at the trachea, which is your windpipe. The trachea travels down and then branches off into the lungs, where it narrows and turns into the bronchus. You have one of each of these in your two lungs, And then these bronchi feed into your bronchioles and narrow even further until they end in the alveoli. And these alveoli are air sacs that exchange carbon dioxide and oxygen gas between your circulatory system, meaning your bloodstream, and the environment. So every time you take a breath, your diaphragm, which is down here, this is your breathing muscle. Every time you take a breath, that muscle that helps contract and expand your lungs pulls air in or pushes it out. As far as normal microbiota of the respiratory system goes, this area is relatively devoid of normal microbiota, although there have been some bacterial species that have been identified in studies, but it's not totally clear in those studies whether they are transient organisms that the body is in the process of removing, or if they are permanent residents of this quote-unquote normal microbiome. So 2 terms to introduce in the realm of lower respiratory system infections are, first, bronchitis, which is inflammation of the bronchial tubes, and second, pneumonia, which is inflammation of the alveoli, those little air sacs that transfer oxygen to your bloodstream, which causes pus and fluid to build up and get in the way of that important transfer of oxygen. Here is the list of infections we will be looking at in the lower respiratory system. We have 3 that are bacterial in origin: pertussis, tuberculosis, and pneumonia. 3 that are viral in origin: pneumonia, respiratory syncytial or RSV, and influenza. And then there are 3 that are fungal: histoplasmosis, coccidioidomycosis, and pneumocystis pneumonia. So let's begin with those that are bacterial. Pertussis is the medical name for whooping cough, which is caused by the bacterium Bordetella pertussis. The mechanism that these bacteria use to cause infection is that they will attach to the ciliated cells in the trachea. And you can see this in the electron microscopy image right here, with the bacteria being artificially colorized in orange, and these little hairs are the cilia on the surface of the cell. When the bacteria attach to these ciliated cells, they release a powerful toxin that kills the cilia, destroys those little hair structures. And we previously learned that the role that these cilia play in something called the mucus ciliary escalator is that they sweep mucus down your esophagus and towards your stomach instead of towards your lungs. Because from the perspective of your immune system, the stomach is a much better place for mucus and microbes to end up because of its very low pH gastric acid. So by destroying the cilia in the trachea, Bordetella pertussis causes the mucus ciliary escalator to stop functioning in this way and allow mucus to start flowing into your lungs instead of being directed towards the stomach. And it's the accumulation of mucus in the lungs that leads to the hallmark sign of this disease, which is severe violent coughing, that it can be so intense that it leads to vomiting, interruptions in your breathing, and in the case of young children and infants, it's totally not uncommon for the coughing to cause broken ribs. And perhaps unsurprisingly, given that coughing is such a major feature of this infection, it is transmitted through droplet transmission, and it is highly contagious. The other scary thing about whooping cough is that it is not very treatable. Even though it is caused by a bacterial pathogen, antibiotics are not very effective unless this disease can be caught in the early stages, because you can kill the bacteria with antibiotics, but if they have already had the chance to release their toxins and destroy the cilia in the trachea, then very little can be done to bring that mucociliary escalator back online until the healing of the cilia has taken its natural course, which of course takes time. So luckily we get protection against pertussis as well in the DTaP vaccine, which we also saw when we looked at diphtheria. And pertussis is what the P stands for in DTaP. Our next disease is tuberculosis. Tuberculosis is caused by the species Mycobacterium tuberculosis. This bacteria is a slow-growing species that possesses a waxy mycolic acid layer outside of its cell wall, which gives the bacteria an additional layer of protection and makes it resistant to many antimicrobial drugs. So tuberculosis is particularly difficult to treat. It typically requires multi-drug treatment that lasts months or even years on end to eradicate the bacteria from your system. And these bacteria, when they do cause an infection, they colonize the alveoli in the lungs and cause these lesions called tubercules, which you can see in this lower image right here. And what we may not realize here in the US is because there's a very low incidence of tuberculosis here at home, it is thought to be one of the deadliest infections in human history. And historians believe that it was responsible for 20 to 30% of the deaths in Europe in the 17th through the 19th centuries. And even today, the CDC estimates that 1/3 of the world has an infection with Mycobacteria tuberculosis, although many of these infections are latent in nature. This map right here gives you a picture of the incidence rate of active tuberculosis infections around the world, where the darker colored countries have a higher rate of tuberculosis cases, and the lighter colored countries have a lower rate. And as you can see, the highest concentrations are in sub-Saharan Africa, parts of Southeast Asia, India, Mongolia, hardly any in North America and Western Europe. So these incidence rates reflect where some of the most vulnerable populations are in the world in terms of public health care to treat such a difficult, gnarly disease. It is also incredibly unfortunate that TB actually first emerged in Europe and was brought to other parts of the world through colonialism. And while many European countries have the resources to where they've been able to largely eradicate tuberculosis, it still has this powerful foothold in many former European colony areas. There is a TB vaccine, but it is not very effective. It only reduces the risk of infection by about 20%. It is only really given to healthcare professionals and people in the military who travel abroad and are at greater risk for contracting TB. The TB vaccine is actually most useful for preventing severe forms of tuberculosis that can progress into meningitis, but it's not very useful for blocking infection full stop. There is also a test for tuberculosis. It's called the MAN2 test, and this involves taking a small amount of purified protein from the pathogen and injecting it into the skin. And if a person is actively infected with TB, then all of those leukocytes, those white blood cells, will produce an immune response that will generate this hardened red swollen area around the injection site. The weakness of this test, however, is that it often produces false positives. For example, if a person has received the TB vaccine, or if they have previously contracted TB and then they've recovered from it, they will also likely produce a positive result in the MAN2 test. So now we're moving on to our third bacterial lower respiratory system infection, which is bacterial pneumonia. Pneumonia is this overarching category that can be caused by both bacterial and viral pathogens, but here we're looking at and focusing on the bacterial causes. And in particular, we're going to be looking first at the typical bacterial causes. We will also discuss atypical bacterial causes of pneumonia in just a few slides. But as far as typical causes, there is one pathogen that stands out among typical causes of bacterial pneumonia. 2/3 of cases are caused by encapsulated Streptococcus pneumoniae, and these cases are referred to as pneumococcal pneumonia. Another of the more common causes is Haemophilus influenzae. The pathogen Haemophilus influenzae is named for the fact that it was once believed that it was the cause of influenza, so that's where the species names comes from. But now we know that that's not the case. Flu is caused by a virus, but the name stuck. Bacterial pneumonia is associated with high fever, difficulty breathing, chest pain, and sometimes blood in the lungs. Treating pneumonia with antibiotics has historically been effective, but it is becoming more difficult as pathogens gain resistance to some of our standard antibiotics that we use to kill these bacteria. There is a pneumonia vaccine, however, that is available to protect against some strains of Streptococcus pneumoniae, and it's called PCV, which stands for pneumococcal conjugate vaccine. It comes in a few forms. Children are able to get PCV13, which protects them against 13 different strains. Older adults can get PCV15, or as of 2021, PCV20, which protects against 15 or 20 different strains respectively. And these are about 60 to 70% effective at preventing pneumonia. In addition, the Hib vaccine is part of the regular infant vaccine schedule. It protects against Haemophilus influenzae, although the primary utility of this vaccine, as we're going to learn later on when we talk about diseases of the nervous system, is actually preventing bacterial meningitis, which can also be caused by Haemophilus influenzae. But there's also the side benefit of preventing bacterial pneumonia. Another special case of typical bacterial pneumonia that we should talk about is Pseudomonas pneumonia. Pseudomonas pneumonia is caused by the species Pseudomonas aeruginosa, which is a common nosocomial infection arising in patients who have been ventilated. Any indwelling medical devices like a ventilator can be a hotspot for pathogens to gain access to the body systems, and Pseudomonas aeruginosa is a common pathogen that is transmitted in the hospital environment. You may remember that it is the most common hospital-acquired infection that is isolated from patients who have been in an inpatient setting for over 1 week, and it can be introduced into the lungs by the presence of a ventilator and then go on to cause pneumonia. Over 50% of people who suffer from cystic fibrosis also become infected with Pseudomonas pneumonia. So it is a particularly dangerous variety of pneumonia for that population as well. And then there is atypical bacterial pneumonia. So atypical bacterial pneumonias can have a wide variety of different causes that are much less common than typical bacterial pneumonia. We are just going to highlight a few of them right here. Mycoplasma pneumonia, which is also known as walking pneumonia colloquially, is caused by the species Mycoplasma pneumonia, and it exhibits airborne and droplet transmission, and it's especially common in community environments like assisted living facilities, for example. Legionellosis, this is also called Legionnaire's disease. This is caused by Legionella pneumophila, and this is actually thought to be a non-communicable disease, interestingly. So in other words, it cannot be transmitted from host to host. Instead, it is believed to be transmitted through water. This pathogen can live in water sources even when that water has low levels of chlorination. And then chlamydial pneumonia is caused by a few different species. Chlamydophila pneumoniae is the most common, but also Chlamydophila psittaci, which usually spreads through contact with bird droppings. Also, Chlamydophila trachomatis, which is one that is transmitted through vertical direct contact transmission, meaning from mother to child during birth. If a mother has an undiagnosed and untreated chlamydia STI, then that can manifest as pneumonia in her infant child. And since we're on the topic of atypical bacterial pneumonia, I thought I would show you guys a news story from 2019 related to Legionnaire's disease. So in 2019, there was a North Carolina State Fair where there was a hot tub on display, and the water in those hot tubs was apparently contaminated with Legionella. And just by walking past the hot tub display and inhaling the steam from the hot tubs, over 130 people came down with Legionnaire's disease, and 4 people actually died. So this gives you a better picture of how legionellosis is not actually communicated. It's not contagious from host to host. It's picked up from this reservoir of water. So this brings us to a few more checkpoints. Firstly, which differential stain that we've learned about in this class would be carried out on a patient's sputum sample, which is saliva and mucus, to determine whether they have tuberculosis. So what stain would you perform on sputum to figure out if the tuberculosis pathogen is present there? And next, which type of bacterial pneumonia would an avian zookeeper be most susceptible to? A zookeeper who cares for birds. We are now moving on from the bacterial infections of the lower respiratory system to the viral infections, which again includes pneumonia, respiratory syncytial virus, and influenza. So we'll start with viral pneumonia. Viral pneumonia, unlike bacterial pneumonia, is not treatable with antibiotics because antibacterial drugs don't work against viruses. Historically, the most common causes of viral pneumonia have been adenoviruses, influenza viruses, or it can arise as a complication of measles or the smallpox. However, as I'm sure we are all aware, coronaviruses have emerged as a major cause of viral pneumonia, namely COVID-19. However, COVID-19 is not the only coronavirus that can cause viral pneumonia, so this warrants a little bit of a deeper discussion about coronaviruses in general. So what is a coronavirus? This type of virus is a positive single-stranded RNA virus, and it has spike proteins on the surface that, under an electron microscope, give it the appearance of having a crown or a corona, as you can see in this image right here. And it is transmitted through respiratory droplets, airborne particles, or direct contact with an infected individual. There are actually 7 known strains of coronaviruses that have human hosts, and many more that have non-human animal hosts. 4 of these are causes of the common cold, very common causes in fact, and these remain largely relegated to the upper respiratory system. But there are 3 that can infect the lower respiratory system and lead to much more severe diseases. And these include Middle East Respiratory Syndrome or MERS, Severe Acute Respiratory Syndrome or SARS, and COVID-19. SARS or Severe Acute Respiratory System is thought to have been transmitted from horseshoe bats to humans, so it's a zoonotic disease that made the jump from an animal host to a human host. The only known outbreak of SARS occurred in 2002 to 2003 in China, and at that time it infected over 8,000 people and exhibited a 10% mortality rate. So it was killing 1 in 10 people who were infected with it, and thankfully this SARS outbreak, unlike the COVID-19 outbreak, the SARS outbreak was contained and wiped out through a very swift and aggressive quarantine measures. And there has never been another known outbreak of SARS since. Then Middle East Respiratory Syndrome coronavirus. It is also a zoonotic disease that's transmitted from camels. It has a high mortality rate, but it is not very contagious. And it is thought that most people who acquire this disease acquire it directly from camels. And then thirdly, COVID-19, like SARS, is thought to have originated from a bat host, and as far as its level of contagiousness, it is quite contagious, with an R0 value of about 3, and that is a term we haven't heard before. R0, which is an R with a little subscript 0, that's how it's pronounced, is R0. R0 is a quantity that is assigned to a disease that represents how many people on average an infected person transmits that disease to. So for example, in this graphical representation, we can see that Ebola has an R0 of 2, and that means that every 1 person who is infected with Ebola on average transmits it to 2 other people. Measles, on the other hand, down here is one of the most contagious diseases known, and it has an R0 value of 15, meaning that every 1 person with measles typically gives it to 15 other people. The Omicron variant of COVID-19 actually has an R0 value a bit above 3. So this figure here is actually outdated and reflects earlier variants of COVID-19 that were less contagious than Omicron. And on the topic of different COVID variants, COVID has evolved pretty significantly over time, and as it has done so, it's acquired a number of mutations in its spike proteins. And remember that the spike proteins are what mediate the entry of the virus into the cell. They allow it to enter. They interact with receptors on the surface of the host cell so it can gain access. And this figure here, which I pulled from a paper, shows the major COVID variants on the left-hand side and the location of mutations in their spike proteins. So a black box represents a point at which the amino acid was mutated between that variant and its predecessor. So you can see how the Omicron variant on the top features a pretty high number of mutations compared to Delta, which on the whole had the effect of making Omicron far more contagious but also less severe than Delta. One explanation as to why Omicron appears to be more contagious but less severe is that Omicron, based on the evidence that we have at this time, appears to infect host cells primarily through endocytosis, whereas Delta infects primarily via fusion. And the cells in our upper respiratory system have receptors that are more conducive to endocytosis as compared to the cells in our lower respiratory system, which may explain why Omicron tends to be accompanied by more upper respiratory signs and symptoms and is less likely to manifest as pneumonia compared to its predecessor, Delta. So moving on from viral pneumonia, we have respiratory syncytial virus, or RSV as it's most commonly referred to as, which is a virus that is named for the fact that, first of all, it's a respiratory virus, but when it infects the respiratory system, it causes the formation of a syncytium, which is this cellular body that is created from the fusion of multiple infected cells. And this is a phenomenon that's induced by infection with the virus. Among adults, RSV is a common cold type virus, but among young children, it tends to affect the lower respiratory system. Virtually 100% of children acquire an RSV infection before the age of 2, and while it has a low mortality rate, many infants require supportive care in the hospital when they're infected. Each year, the US sees somewhere between 60,000 and 80,000 children under 5 being hospitalized with RSV, and it's the most common cause of bronchitis in infants and toddlers. It is also pretty dangerous for seniors because at least as many older adults are hospitalized as children under 5 each year with RSV infections. RSV typically follows a seasonal pattern similar to the flu, and in the fall of 2022, there was a strong surge in RSV infections that was thought to have been partly the consequence of children being sheltered from exposure during the COVID-19 pandemic. Unsurprisingly, all of the same social distancing and mask wearing measures that protect against COVID-19 transmission also protect against RSV transmission. And so during the pandemic, a lot of fewer babies and children caught RSV, which is a good thing. But once things got back to quote unquote normal, those exposures started happening. And now there was this lack of herd immunity because there were so many children who had just never been exposed in their lives. So RSV just spread like wildfire. Luckily, there is a vaccine under development from Pfizer. It is a maternal vaccine, meaning that it is given to women while they were pregnant and their immune system generate antibodies, and those antibodies are passed on to the gestating baby so that when the baby is born, the baby already has protection against RSV. The baby does not have to be vaccinated because the baby's mother was vaccinated and her body generated the antibodies on its behalf and then passed it on to the baby. It's about 82% effective at preventing RSV infection during the first 3 months of an infant's life and about 70% effective through 6 months. So the protection does wane, but in those critical first few months, the protection level is at its highest. And a checkpoint related to this vaccine, the Pfizer maternal RSV vaccine relies on the action of which class of antibodies that we learned about back in chapters 17 and 18 on the immune system. Our third and final viral infection of the lower respiratory system is influenza. Influenza viruses are divided into 3 types: Types A and B are the causes of the seasonal waves of illness, and type C causes mild non-seasonal illnesses. Influenza viruses, as you probably know, exhibit something called antigenic drift, which we learned previously is the rapid mutation of protein spikes, which allows the virus to evade host immunity by continually changing the component of your immune system that your immune system has been trained to recognize. And this means that a new vaccine has to be manufactured every year to protect against influenza viruses as they change and mutate. The way that these vaccines are made is through extensive global epidemiological monitoring, where epidemiologists look at the type of viruses and the nature of their mutations that are occurring during the summer in the southern hemisphere, which is actually their cold season, of course. And then we in the northern hemisphere are in our non-flu season when the south is in its flu season, and vice versa. So by monitoring what's happening with the flu viruses in the opposite hemisphere, epidemiologists can make predictions about which variants will be prevalent and how the variants are changing and what will need to be covered in the next vaccine. Sometimes those predictions are spot on, but sometimes they aren't because the virus is always mutating. And so one reason why the flu vaccine tends to offer lower protection levels than other vaccines is because it's a matter of making predictions on a limited timetable, with limited evidence about what's going to be the most prevalent in the coming season. The flu has a pretty low mortality rate of less than 1%, but it has a very high incidence, meaning that many millions of people contract the flu every single flu season, and so there are a large number of deaths attributed to the flu, particularly among the elderly and vulnerable infants, despite the fact that it has a low mortality rate, just because so many people get it. So getting back to these spike proteins and their mutations, the flu virus exhibits two different types of spikes on the surface of its envelope. The first type is the H spikes. These are named for the fact that they are composed of the protein hemagglutinin. And this hemagglutinin is the component that mediates attachment of the flu virus to the host cell, meaning it attaches to the receptors on the host cell and initiates the penetration process. The other type of protein spike is the N spike. These are named for the fact that they're composed of the enzyme neuraminidase, which is the component that allows the virus to bud off and exit the host cell. And you may remember when we learned about antimicrobial drugs that Tamiflu inhibits the neuraminidase or the N spikes, and therefore Tamiflu prevents the budding or the release stage of the flu virus. And if these H spikes and N spikes sound familiar, or at least letters H and N do when talking about the flu, that's because the different strains of the flu virus are named based on the H spikes and the N spikes. For example, H1N1 is the swine flu, capable of infecting mainly pigs, but also humans. H5N1 is the avian flu or the bird flu, which has been known to jump from birds to humans. So it's the H spikes and the N spikes, that the unique combinations of these proteins that a flu virus possesses, that defines its host range. So in this checkpoint, we're going to look at some historical flu virus case information. In the 2017-2018 flu season, 45 million people in the US caught the flu, and 61,000 people died from the flu. And this was the worst flu season ever recorded since we started keeping records on flu seasons in the US. It represents 2 to 3 times more cases and deaths than the average flu season. So how would you classify the pattern of incidence of the flu in this year, in this season, in terms of whether it is sporadic, endemic, epidemic, or pandemic? So we are nearly finished with our diseases of the lower respiratory system. The only ones we have left to cover are the fungal infections. We have 3 fungal infections, the first of which is histoplasmosis. Histoplasmosis is caused by a dimorphic fungus, which you may remember means that it has both a yeast and a mold form that it can transition between depending upon environmental conditions. And the species name is Histoplasma capsulatum. Usually, spores of this dimorphic fungus are transmitted through the inhalation of airborne spores found within bird or bat droppings. However, most histoplasmosis cases, most infections are subclinical and not serious and self-resolving. But symptomatic infections are associated with a fever, cough, chest pain, and fatigue. The most susceptible people are the immunocompromised. In the United States, this disease is most common in the Mississippi and Ohio River valleys. Ohio River valleys where antibody surveillance has shown that as many as 75% of people living in these regions have antibodies for this pathogen, meaning that it is endemic and very common in these areas, and most people have been exposed but probably never developed a symptomatic infection. In our region, an endemic fungal infection is coccidioidomycosis. This is the next one on our list, also known as valley fever, also known as San Joaquin fever. It's named for the San Joaquin Valley in California, which is another area where it is an endemic. It is caused by Coccidioides immitis, which is another dimorphic fungus also transmitted through inhalation of airborne spores, but these spores typically reside inside the soil. People with weak immune systems are particularly susceptible and have been known to become infected by, for example, simply driving through a dust storm that has kicked up the spores of this pathogen. Associated signs and symptoms are much like histoplasmosis, such as chest pain, coughing, fever, and weight loss. The coccidioides pathogen, when it gets in your lungs, it causes spherules of spores to develop in the tissue of the lungs. And the incidence in our region, the Southwest is growing due to our aging population as well as drought, which causes the soil to become drier and more capable of aerosolizing and kicking up these spores for transmission. You may notice on this map here, there is an outbreak pointed out in a sort of unusual area of northern Utah. And that outbreak in 2001 was actually linked to inhalation of spores by people participating in a dinosaur dig. Our final infection is pneumocystis pneumonia, caused by the pathogen Pneumocystis jirovecii, and this pathogen was actually considered for a long time to be a protozoan and was only more recently discovered to be a fungus instead. In fact, the previous textbook that we used in this course was still unsettled on the matter of whether this was a protozoan or a fungi, but now we know it's a fungus. It infects the lining of the alveoli and it forms cysts. This pathogen most commonly infects infants or people who are immunocompromised, in particular, people who are affected by AIDS. It is the leading cause of pneumonia in people affected by AIDS. And so now that we have finished our look at the lower respiratory system infections, this means that we have also come to the end of chapter 22.